let's get a start on that. First of all, I'm just going to go through each of the doctors and their attempts to deliberately force me to live with this disease. They've used every insult in the book. Oh, you're crazy, you're stupid, you're psychosomatic, that doesn't exist, there's no such bacteria, you name it, they've tried it. Oh, we can't use those tests because they're, that would be illegal experimentation. So it's illegal experimentation to use a test developed to identify infections, but not to refuse them for the purpose of not identifying an infection. Sounds a little bit cockeyed to me. So we're going to start with Dr. James Brownlee from European Infectious Diseases. Now, this prick, and I will call it, this is going to get personal, because this is personal. These guys have stolen 6 years of my life. They've caused me agonising pain, and I've had about enough. And it's this constant half treatments and improper treatments that have made, and ignoring the reinfections. Basically, they've made this so resistant that they've created their own superbug. So, yeah, it does get a little bit personal. But anyway, now this guy is the first one that really upset me. For the simple fact, he sent me home saying I was psychosomatic, that my doctor shouldn't give me antibiotics because I don't have an infection. I have no signs of infection. He refused to test for group C and G disgalactae via any means, and sent me home with, and I forgot to highlight it, but he sent me home with, you'll see here, erythrocytes in my ejaculate, so basically bleeding testicles, claiming I had no sign of infection, and expected me to be nice about it. So when I got upset with him, he proceeded to give me an antibiotic as a peace giving, an antibiotic that I had already explained to him had been rendered useless against this bacteria, against this infection. He didn't care. The second one I saw was Dr. Sandeep Mandel, Jandeep Mandel, and he recognised the gram-positive cokies in sputum, right there, highlighted on the front page. And he also stated on the second page there that he would speak to infectious diseases about running the pathology mentioned previously of the M proteins, C5As and the C peptides, which he then came back and said, oh no, he can't run those tests. Those tests aren't available. Well, that's an outright lie, because I've proven that not only are they available, but when I actually got them done, I had to get that done again through private testing, which took me 4 years. 4 years to find a way to get done. Past the blockade of arm-crossed doctors saying, we can't help you, we won't help you, we will not identify this. Not only did I find out that they are available, but they are actually commonly used. The centre that I went to actually said they do 200 of those a month. So there's nothing rare, there's nothing strange, they just didn't want to do it. And they're not overly expensive either, so now the next one we're going to go to, then we went on to the Central West Specialist, Dr. Bryant, the ENT. Peter Bryan, the ENT, said, basically told me that with a history of sinus and headaches, from an ear, nose and throat point of view, I could see nothing wrong. Now, all he had was an x-ray and a scan, and he was actually requested to have a camera to put up my nose and check to see if there was anything that could be seen in ways of infection. This was requested by Dr. James Brownlee at European Infectious Diseases, and also later on by, I think it was Dr. Mandel. So I did. So I went and I saw him, and he refused to put the camera up my nose, claiming there was no sign of infection and that he's not doing that, even though he's paid out of my pocket. It's not costing the taxpayer. It's costing out of my pocket $200 to get him to put the camera up my nose. He refused. And following that, my GP ended up giving me some antibiotics, in which case this necrotic tissue and then this septic tissue came out a couple of days later, before blood another couple of days later, before it cleared. Now, if he had put that camera up my nose instead of claiming that there was no signs of infection, he would have seen that there was necrosis up there, and he would have been able to help identify. Instead, he chose to do everything he could to prevent it. He also gave me insults about my mental state and told my practicing general practitioner that he should not give me antibiotics because I don't have an infection. So now we're going to go to specific case studies here, which is this what I'm supposed to wait for? This necrosis to eat its way out of my sinuses before an ENT does their job? No, I don't think so. Streptococcus dysgalactone. Left untreated, that necrotizing sinusitis would have eaten its way out. It's actually a form of necrotizing vasculitis, so it's an actual reduction rather than an inflammation. In controversy to necrotizing fasciitis, which is another one of the symptoms of Streptococcus dysgalactone, and that happens to be another case study, and that was transferred from a cat. And there's other ones there that we'll get into later, where with a long story, but basically there have been people with losing their entire fingers, losing chunks of flesh, having their entire sleeve of skin removed from the necrotizing mucinosis, which is another symptom here that we'll discuss in a little while when we get to it. Now, then we move on to Dr. Indy Sundaradara at Westmead Infectious Diseases, and Dr. Indy Sundaradara said that he ran 7-day cultures because at the time I believed the problem with it being identified was that it wasn't, that it has been known to be a complicated bacteria to grow. Since I started building my own cultures, which is after these guys, because I didn't believe a word that came out their mouths, I proved that bacteria does grow in a day or two, no dramas whatsoever. It's just they've either used a gram-positive resistant media such as McConkey, or they've just outright tampered with the samples or the paperwork. It's the only way they came up with nothing in their growth, with nil growth from my urinary tract, which therefore they claimed there was no streptococcus in oral or skin flora too, which I found amazing, seeing I've got those listed well and truly as gram-positive cochies on nearly 4 years worth of cultures. They're identified as gram-positive cochies plus, gram-positive cochie plus, gram-positive cochie plus, and I think I've got some copies of that in here somewhere too. I'm not sure, but if I have, we'll flick through the pages and I'll show you. He states that I remain disabled by my symptoms and report ongoing burning of his skin, throbbing of the veins and difficulty moving hands. Now, and that no new symptoms in the interim. Well, in that he stated that no new symptoms doesn't mean that the symptoms that are there aren't reoccurring and they're not constant. Now, he also put me through a $2,000 PET scan, which is the scan that I showed you that they say they can't see my symptoms in, as well as, and we'll get to Dr. Matthew O'Sullivan in a minute, Dr. Matthew O'Sullivan, who actually puts in writing that he could not see any of the symptoms that I've shown you in the photographs today, in the photographs. So, now Dr. Zandeep Mandel, and when I told him that I wasn't happy that, you know, Dr. Indy Sundararaja, that I wasn't happy because he was ignoring what he was being told, and he also denied his ability to run the monoclonal activation systems and the G kappa lambda ratios, along with the C peptides and any of the others on that regular testing forms. So then we moved on. So he sent me to his higher up associate, Dr. Matthew O'Sullivan, who said, Jared showed me multiple photographs of various parts of his body taken on his smartphone, which he felt demonstrated abnormalities. However, I could not see anything abnormal in the images. He is convinced his symptoms are related to a persistent disseminated infection with group C or G beta hemolactic streptococcus. So, well, I come back to the fact of I'm growing a streptococcus. I've confirmed that's a gram-positive cokie. I've confirmed it's a streptococcus, not a staphylococcus. Although in recent times I have had secondary staphylococcus as well, which is concerning, but that's another matter altogether. As to which strain of streptococcus, well, I don't know, because they're deliberately making sure they don't identify that. In here I've also got some of the pathology that they ran, including at one stage the G proteins, which noted that one of the paraproteins was raised, and they didn't bother following up on that either. We've already been through these guys. The only other one that I did show to infectious diseases, which followed up on the previous mentioned mucinosis, which has been diagnosed right here. Now, mucinosis is a breaking down of collagen, subcutaneous fat, or thinning skin syndrome. I also showed to both Dr. Indy Sundararaja and Dr. Matthew O'Sullivan that the changes between when things were bad and antibiotic treatment. They claimed they couldn't see any differences in the quality of the skin or the colours of the tips of the fingers or anything like that. It was just photo imaging. They can claim that all they like. I've got 100 people, including multiple nurses and frontline staff, who have said, wow, you look heaps different, even your skin. Another excuse they claim that I didn't have any signs of necrosis is that I didn't have any CRPs or ANAs, which are the main markers they're using for necrotic inflammation. You can't have necrosis without inflammation. Well, the first thing I already discussed is the difference between necrotizing fasciitis and necrotizing vasculitis. Necrotizing vasculitis is a reduction and a shrinking and closing of the blood vessels, basically, and causes the deadening of flesh around it and skin. And now this mucinosis rubbish can turn necrotic as well, and you can have entire sleeves removed, which is just horrible. But in the basic microbiology study group, they used the sheet of a Lansfield agglutination test to explain the CRP connections. And basically, as you can see, the group A is black because it is a CRP test positive, and then group B, C, D, F, G are blue because they are CRP test negative. And there's another point towards picking out the particular streptococcus that of concern. Is that the CRPs say that it's not group A streptococcus. So while they're putting our streptolysin up to the range that only suggests group A streptococcus, they're refusing tests for any other streptococcus on the grounds that you don't have a high enough streptolysin. They're claiming that the CRPs say you haven't got necrosis, when in actual fact the CRPs related to don't exist in relation to any other streptococcus bar group A. Now, we also went through the PET scan, and I'll put the I'll put a copy of that scan in there as well, basically saying that there's nothing wrong except a possible nodule in the chest. So basically they wanted to go down my throat and go into my chest with a surgical procedure. Again, another procedure that was unnecessary for no purpose except for feeding their own ego and creating an expense for the medical system. Now, you'll also notice earlier when we discussed the results from the scan about where the myositis was in my hand and the other side across the knuckles and the back of my hand. Now, I'm putting to everyone that if they hadn't have ignored that outcome, and this didn't say that there was no such thing, no symptoms available, which are clearly is clearly falsified, and the infectious diseases wouldn't even look at this scan, let alone try and connect it to any of my symptoms. Especially Matthew O'Sullivan, who told me that, oh, we don't question our colleagues. Well, and we'll get into the medical code of conduct in a little while, and we'll see if he's supposed to question his colleagues so that the patient can be informed of their condition. Now, as I showed you, the difference in the other side, not where the myositis is, but in the other side, I wonder if that could have prevented any of the damage on my hand, on the pinky and ring finger and up into the face of my hand. I wonder if that was a preemptive notification or, again, another thing they chose to ignore because, well, I have no rights as a patient. Now, in relation to how long I've been chasing this up, and even with the general practitioners I've been seeing, and one of my longest practitioners who more recently we had a bit of a discussion that ended that relationship, and I'll explain why. But I wrote this letter, and you can see it's dated is it the 18th of May 2018, specifically requesting strep C, strep G, and pepto, and at that stage clostridium difficile was still on my list. That was before I recognised that clostridium difficile was actually a gram-positive bacilli, not a cokie. And the constant raised white cells and neutrophils that have been passed through all the medical systems, including infectious diseases, the ENT, and the physician, and through urologist, which I haven't got his report because I had a falling out with the doctor who that report was sent to, so I will get that soon. But basically shows I've got a history since 2016 on file here today, right through to 2020. Yep, till 2020, showing continuous raised high white cells, neutrophils. Now, all the GPs, infectious diseases, the physician, the ENT, and the urologist all say, "Oh, that's nothing. That doesn't mean infection." Well, white cells is the inflammation of the immune system, and by the time you get up to twice the range, your immune system is pretty messed up. And neutrophils are your body's protein relation to bacteria. So by deliberately refusing to identify those two blood counts, they're basically going out of their way to prevent to not have to follow up on a possible bacterial cause. And I'll also bring your attention to the point of 7 times the normal amount of pus in my urine. And again, this has been through all of the and I can show you the extension of time of that as well, with a second case of actual higher pus in the urine count. And this is where we get to the urinary tract infection that I've proven that the laboratories are refusing to identify, and infectious diseases, and basically anyone who sees it doesn't care. It's not their problem. And my argument is it is your problem. Now, and we get to the falling out. Sorry, the next doctor I saw was Dr. Nicholson, the urologist, who again put me through a medical procedure where he put down the white cells, neutrophils, and 7 times the amount of pus in the urine. Basically, put it down like it didn't matter. It was irrelevant. These are the 3 magic points for a bacterial infection to start with. But then I, after the urologist, he sent me into, he did a procedure where he went down through my urethra and checked out the bladder and all that sort of thing. And I asked him while he was doing that if he could take some samples to put out for extended culture, because nothing's coming up and they should be. He said, "Oh no, we do that in urine. There's no reason for that." And I said, except for the fact that whole urinary tract is supposed to be a sterile site. So anything that he took that anything grew, well, that's irrelevant. So basically after that, all I ended up with was no answers, 3 days of peeing blood, and then my stomach blew up like a balloon for about 3 weeks, until it started spreading to my bowel and I started crapping blood. At this point, I went back to my doctor, Dr. Sean Howlett at Wall Street Medical Practice, and I had at this stage my culture plates. I had my proof that it was growing from my urinary tract. I had my proof that it was growing from my mouth and skin, which basically he screamed at me, "I don't have an infection," and that I don't have any rights. I have to get everything from a doctor. And because I got upset and we had a bit of a screaming match, because I told him outright that healthy people don't shit blood, and that if I was going to be a prick, I could use what I know about this bacteria against him in a heartbeat, which I don't deny. I can't. I can't condone my behaviour 100% of the time either, but I'm in pain and in fear of my life, and they're just screwing me around. But anyway, from there I got a letter saying basically, I can't help you from here on, and don't come back to my practice. So his idea that healthy people shit blood, and if they argue about it, they should go away and not come back. And then it came back to Dr. Karana Keat of Campbelltown Hospital, an immunologist. Now, an immunologist that again was brought up with white cells, neutrophils, and urinary pus, claims there's no bacterial infection. Now, besides the fact that he's an immunologist, so knowing that white cells and neutrophils is the bacterial inflammation markers, and that 7 times the normal range of pus in your urine is not normal. If you've got that, you've got something wrong, and someone needs to find out what it is. It's just ridiculous. But in his letter back, he basically tells me that I need to stop smoking. Well, I'm a smoker. Deal with it. He told me in the start, if I didn't stop smoking, that he wouldn't help me, and that's another thing that we're going to have a discussion on when it comes to the code of conduct, as far as the medical practice in Australia actually giving a rat's ass what that is. He also noted that I responded to other antibacterials, and he basically told me that Matthew O'Sullivan and Dr. James Branley of Nepean Infectious Diseases and Westmead Infectious Diseases informed him to tell me that I have to stop because I'm pissing them off, and that even if I get this identified, it won't help me because my research is illegitimate. So the first thing I'm going to put out here is that my research, as far as the research goes, I don't claim any affiliations. I don't claim to have gained anything. None of that is responsible for me. That is direct. That is directly the ownership of the people who wrote it, the people who professionally instigated it. It has nothing to do with me. It's actually a part of, all I've done is point out the fact that it's a part of their medical training areas and they should already know it. And he also put into the fact that it may well be that requires Bactrim prophylaxis Mondays, Wednesdays and Fridays to see if it resolves his symptoms. Okay, first of all, we'd already discussed the fact that Bactrim was no longer effective against this disease. So again, suggesting that someone takes an antibiotic that has already been rendered ineffective by previous lies and mismanagements. That just shows that you don't care. You didn't listen to a damn thing. And the second part of that is suggesting an antibiotic with a 12-hour half-life. And the only way I can really explain that is that it holds a level of bacterial resistance for 12 hours where you can then continue that and still have protection to your next dose. So he suggests a 12-hour half-life antibiotic every 3 days. Well, that's well outside the ranges of its 12-hour half-life. Therefore, being a complete disregard for the antibiotic treatment itself. And this sort of behaviour is what's caused conditions like mine and superbugs in the industry. They keep blaming, they started off blaming people in the 80s for not taking their full course of antibiotics. Now they just refuse to give it to you. They refuse to give you treatment until your disease is gone. They're using things like symptoms-based medicine, which they say they can claim they saw or they didn't see a symptom anytime they want. And also we look at some of the symptoms. I mean, you look at symptoms like the urinary tract infections, the muscular pains, the joint issues, and they go, oh, we'll pick 3 of those. Now those 3 symptoms might be, say, lethargia, urinary tract infection, and and joint pain. Well, that's got a range of infections that's 200, 300 long. I don't know, it's huge. But to range a treatment on that is based on a guesstimation. They'll pick 3 of those and say, well, if you haven't got one of those 3, you haven't got an infection. That's just how it goes. But you've also got to look at the treatment value of that. Now, you take those same 3 symptoms and relate them to the actual disease that's causing it. So one might be from Streptococcus group A, and you might have just started with a sore throat and it might have just snuck away a little bit. 7 to 10 days of pretty much any antibacterial agent will prevent will kill that disease and prevent most comebacks. If it was from gonorrhea or something like that, a shot of ceftriaxone and a couple of azithromycin, you're laughing. Then you get into a complicated staphylococcus infection. Now, staphylococcus infection is usually about 2 to 6 weeks, depending on the severity of the disease. But how are you going to know that if you don't know what the disease is because you're refusing to identify the bacteria? Another part, and then the next one says Streptococcus dysgalactiae. Well, its treatment is 6 to 12 weeks. So how do you gauge from symptom-based medicine that you're treating a disease, not just symptoms, and creating a superbug by improperly treating the disease? I believe this is an intentional misguidance by medicine to expand their growth, and along with, as we discussed in the symptoms listed in the case study, in the research study, sorry, the range of what they're calling immune disorders that are actually underlying diseases of these types that they refuse to identify proves that they're just trying to make money out of it, and they don't care how much you suffer in regards to it. Now, the longest treatment for any of these symptoms that I'm aware of is is leprosy. Now, it was a surprise to me to find out that we have 3 or 4 cases of leprosy a year in Australia. I didn't realise we'd ever have that. But the Bureau of Statistics is awesome. But the treatment for leprosy is 12 to 18 months. So if they're only treating your urinary tract infection for 10 days, how are they treating leprosy? They don't. They test for it. They have to test for it. And a lot of these things they do test for, but some of them they don't. Simple fact is, when you've got responses coming back saying gram-positive cokie, gram-positive cokie, gram-positive cokie, things like gonorrhea, Campylobacter, Helicobacter, and Klebsiella, and some of the others that, and leprosy, which is a bacillus, which I've been tested for 15, 16 times as a joke. Basic medicine should know the areas, the human biomes of what's native flora and what's not. And they should know that at least the groupings of bacteria, that a gram-positive cokie can only be staph and strep. Gram-positive bacilli is clostridiums and listerias and Campylobacters and things like that. And then you've got your gram-negatives, which is your STDs and syphilis and E. coli's and Klebsiellas and things like that. So they should know these basic outlines, so that when they get a test back, they should be able to go, oh, yep, I see that. But that's only if they come back. And this is what we're here. We need to make sure that our labs are not tampering with our samples. We've got to make sure our infectious diseases and our specialists in immunology and urology, and they're doing the job. I mean, a urologist that doesn't know, that isn't looking out for what infections are affecting his area of speciality, sorry, you're out of line. Your responsibility is to know what's going on with people's urinary tract. Dr. Keat, it's your job to know what's going on with people's immune systems. It's your job. How about you get off your backside and do it? As far as infectious diseases goes, well, you're just deliberate. I've had enough of you. And that's why I'm doing this today. Now, I did put most of this file, including the fact that infectious diseases are deliberately refusing identification of symptoms, the proof that they're lying about the availability of testings, and I did get this as far as Mr. Brett Hazard. Now, Mr. Hazard sent back to me after I got a phone call from Rebecca McLeod from the Patient Safety Partners in Bathurst Base, that I was actually on antibiotics at the time and my symptoms were being minimised. The disease wasn't treated to completion. So here we are back in reinfection and serious consequences again. Instead of offering me help to try and get the bacterial identified that, well, I suppose at that stage I didn't really have the proof that I had that, but instead of helping me with that, they sent me a letter saying basically continue letting doctors do what they're doing. Keep letting doctors screw you over. If a study comes up for Streptococcus dysgalactiae, we'll let you know. So, Mr. Hazard, our Minister for Health and Ethical Medical Research, says, after proving that his infectious diseases team are deliberately refusing, and so many GPs are deliberately refusing to identify the symptoms and the pathology of an invasive infection of necrotizing values, is I'll continue to let them doing what they're doing. Continue treating your symptoms. Don't try and find the disease, and this has to stop. I mean, you've all seen that Wayne Swan floating around your screens at the doctors with his big proud voice saying, hey, symptoms-based medicine, that's the best medicine. Well, that's a lie. And as we've discussed a moment ago, I can explain the reasons why that's a lie. And I'm also going to discuss that, because they're using symptoms-based medicine, they're refusing to identify the baseline diseases. So then they go, oh, it's a mental health issue. And I'm going to bring up the point here that of the mental health specialist that I saw at Blaney Hospital was a referral from a Dr. Niam Saman. Now, this guy told my wife and her friend that he would organise this testing for me. And then when I turned up on the day, he said, no, I can't run those tests, just psychosomatic. So he sent me to his psychologist. His psychologist sent him back a report basically saying that, he can't explain my conditions from a mental health point of view, and that he can't see that I would stop until my concerns were met. To which Dr. Saman basically said, doesn't matter, I don't care, I'm not running those tests, I can't run those tests. No, that's a lie. He could have run them at any time, he just chose not to. So now we're going to work on the continued issues with this infection. Is, as we discussed before, this is an orally contagious bacterium, so it can easily transfer from person to person, animal to person, and surface to person. So I've had concerns about my family for a very long time, pretty much as long as I've been sick, and again with no follow-ups and no one willing to help me to make the connections. I ended up with my daughter having, from a previous injury, she ended up back in Westmead Hospital with necrosis and osteomyelitis. Again, not a single doctor took a swab of the wound, or did anything to try and identify the bacterial cause. They just went, it's necrosis, and threw antibiotics at it, or it's infected, threw antibiotics at it, and then necrosis. And again, infectious diseases, Dr. Britton at Westmead Children's Hospital refuses to do anything in regards to identifying the streptococcus that was discovered when I took a swab of her wound. Now we can go through the fact that, again, we've proved this is a gram-positive cocci, small colonies and large clusters. It's the same streptococcus, or a streptococcus. My wife helped me put together an entire folder of information that links her symptoms, her lack of pathology, and the connections to this disease to Dr. Britton, to which he basically said, well, it's an upcoming, it doesn't exist, blah, blah, blah. I'm not running those tests. I can't run those tests. So he said the only test he will run is a streptolysin O test, which, again, as you recall, 128 plus 10%. I don't know if you can read that, but hers was 181, I think it is, because you can hardly read it. And he says, it's under 200, so it's under the maximum safe level for Streptococcus group A, but only just. And I can prove that even as a younger child back in 2017, she still had, as I do, the raised streptolysin O test. This has probably gone a little bit pear-shaped because it didn't go according to plans as I preferred, because as I said, medical stuff does go backwards and forwards, and it comes down to different doctors and the outright refusal to identify this bacteria. Including the file that I'm going to download, I've included some of the other case studies that link the lack of CRPs and the minimising of the immune response to this bacteria in regards to necrosis and other things. Necrosis, arthritis. And this is a good one. This is one I suggest everybody actually look up the full version of. This case study from Virginia Boone, linking liver, kidney and heart disease. Now we mentioned this earlier, and I like this very much because not only does it very thoroughly link the conditions of liver, kidney and heart disease to this bacterium, but she also included in that research the connection between communal dogs and the houses that they visit, and the transfer between them and the people that have become ill. My only dislike to that is that she does bring up the fact that many of her subjects died while she was doing the study. And it's the one thing I hate about these studies is that they allow people to die while they are running them. Instead of going, hey, we think this is what it is, we found it in you, we'd like to treat it and see if it helps your fatal conditions. No, they don't. They wait and see what the outcomes are. And that just irks me to death. I think this crap needs to stop. Now, as we discussed earlier in the piece, I'm going to talk about some of the medical frauds